Good afternoon, everyone, and welcome to this webinar presented by the UCLA Center for Health Policy Research titled Perspectives from the Field, Innovations in the Low-Income Health Program. My name is Max Hadler. I'm a research associate at the center and one of the co-authors of a new center report that we will be discussing during the webinar. The event is part of the Low-Income Health Program evaluation being conducted by the center. And we just wanted to acknowledge and thank the funders of the Low-Income Health Program evaluation, the Blue Shield of California Foundation and the California Department of Healthcare Services. For general information on the evaluation and the center's other projects, please visit the site listed at the bottom of your screen. Now, before we get started, please note that a few housekeeping items are included in the notes pod on the right side of your screen. It includes a link to the report we'll be discussing here, as well as a previous report on system integration under the HCCI program. And also, please note on the bottom right corner of your screen, there's a Q&A pod if you'd like to submit any questions or comments that we can get to at the end of the presentations. At the top right of your screen, there's also a files pod that has a copy of the slides we're going to be reviewing during the webinar. So as I mentioned, this webinar was inspired by a report released by the center in November. The title of the report is Safety Net Delivery System Redesign in California, Innovations in the Low-Income Health Program. The report is available in the notes pod to your right, as well as on the center website under the Publications tab if you select Latest Publications from the drop-down menu. So we're going to hear from 4 speakers today, starting with Dr. Nadi Porat. Dr. Porat is the Director of Research at the UCLA Center for Health Policy Research and a Professor of Health Policy and Management at the UCLA Fielding School of Public Health. She's also the lead author of the new report and will describe the major findings from the center's latest research on California's safety net. Next, we'll hear from Dr. Jennifer Tuteur, who, among many other roles, is the Medical Director of San Diego County's Low-Income Health Program. She'll provide comments on San Diego's experience with changes in safety net care under the Low-Income Health Program. Next, we'll hear from Dr. Alexander Lee, who is the CEO of the Ambulatory Care Network at the Los Angeles County Department of Health Services. Dr. Lee will offer insight into Los Angeles County's experience with safety net redesign, including efforts to develop patient-centered medical homes and integrate physical and behavioral health care services. And finally, we'll hear from Rachel Wick, Program Officer for the Healthcare and Coverage Program at the Blue Shield of California Foundation, who will provide remarks on the Foundation's continuing work into 2014 related to delivery of care in California's safety net. And then, time permitting, we'll have a question and answer session after Rachel's comment. So without further ado, I'll turn it over to Nadi Porat to discuss some of the findings from the center's report. Nadi?
Good afternoon and welcome to this webinar discussing the Safety Net Delivery System Redesign report that was recently released, as Max just mentioned. Have a relatively dense slide pack with a lot of information that summarizes the findings of the report. I'm going to try to go through relatively rapidly and highlight the most important findings of the report. And I do recommend that for further detail and information describing exactly how things are organized in this report and the information about the Low-Income Health Program, please read the report. So we're going to start by, these are the report authors, and we're going to start by a quick overview of the Low-Income Health Program. Just to bring everybody on the same page. I think everybody who's joined this webinar is probably familiar with this particular 1115 Medicaid waiver called Bridge to Reform. 53 California counties participated in the program. The one important note that is pertinent to the rest of this presentation is that 10 of the counties were the ones that previously participated in the Healthcare Coverage Initiative, and these 10 are called legacy counties. And then there are a number of counties that participated in the Low-Income Health Program for the first time, and those are referred to as the new counties. That's the primary distinction. The a little bit more information about the low-income health programs provided here, but of note is that the legacy counties obviously had a longer period of involvement in delivery of care to the low-income uninsured populations in California, and therefore had experience in building networks and delivering care. Probably that's going to be reflected in some of the findings that you see later on. As everybody knows, the low-income health program is going to provide the opportunity for transition of the individuals that are called the Medicaid coverage expansion part of the program directly into Medicaid. The other populations that are higher income are going to be transitioned to the exchange. The next slide highlights the LIHP implementation process, and of note here is the period of time that we were referring to in all of the data that we're presenting is as of March 2013. That means that there were a few counties that had just gotten the program started and they were not able to participate and provide the information that we were asking. So that means Placer, Sacramento, Monterey, and Tulare are not participating in this particular report. This is a visual of the California counties that are participating in the LIHP program. The dark blue identifies legacy counties. The next lighter shade are the counties, other counties that joined the LIHP program for the first time, and then of course the CMSP counties, which is a number of, at the point of the survey, were 34 California counties participating in the CMSP, and Yolo County also joined later on, so there are 35 counties under a CMSP, and we collected that information presented in this report from the CMSP rather than individual counties. Just a quick reminder of the number of people that have received, have been enrolled in the program. As of June 2013, over 600,000 individuals were enrolled in the program, but cumulatively over 800,000 individuals have been touched by the program. Now, the content of this report focuses mostly on measuring system redesign. Here are the factors that we specifically looked at. There are multiple ways you could look at system redesign, but these are the measures specifically that we have looked at that focus on infrastructure development, changing patterns of care seeking and care delivery, and a little bit focusing on care integration, particularly between physical and behavioral health. The data that we have for this, that we used, were collected through two different mechanisms. We interviewed the LIHP administrators, we surveyed them, and then we followed with interviews to get more depth of understanding of how the programs are being implemented. And, there were 16 participating LIHPs. One of those LIHPs is the CMSP. So 15 counties and CMSP were participated. 4 of the LIHPs, as I mentioned earlier, did not. The LIHP we also surveyed LIHP providers, particularly focusing on clinics and medical groups or individual providers if they were part of the county network. So we received responses from 60 clinics that represented 13 LIHPs. We do not report the data from the medical groups and individual physician practices because there were not that many of those respondents, and those results were substantially different enough, and there were not that many of them, so we are not including them in this presentation. So now we're moving on to infrastructure development. A quick overview of what the network of each one of the participating LIHPs looks like. 3 of the LIHPs, of course, had a much larger network than the others for obvious reasons, including CMSP, Los Angeles, and Orange County. And from these LIHPs, we actually selected a sample of providers rather than conduct a survey with the universe of providers. But we attempted to conduct a survey with the universe of providers in the remaining LIHPs. We asked the contracted clinics about hiring new employees due to their LIHP participation. As you can see here, many clinics reported that they actually had done this, and the most commonly hired type of individual were medical assistants and nurse practitioners, and then of course you can see other types of individuals that were hired by the clinics in order to participate in the LIHP program. They needed to increase their staff, and these are the kind of staff that they hired. We also asked the low-income health programs about methods of assessing network adequacy, and as you can see, these are the types of efforts that were conducted by LIHPs. The most common method was appointment wait time, and but then there were other methods as well that were used. We did ask also about the frequency of assessing adequacy, and 12 of the LIHPs told us that they are doing this on a quarterly or more frequent basis. We asked the LIHP programs to tell us about the barriers to providing specialty care, particularly the type of specialties that were in high demand or low supply. And here are the results that you can see here. Gastroenterology and orthopedics were frequently reported as being in low supply and or high demand. And there are other providers, obviously, that are needed, and there were barriers in identifying these specialists participating in the program. The reasons for that were mentioned by the LIHP programs included not having enough specialties in the area, specialists that did not have openings, or that specialists that were not interested in contracting because of the reimbursement rates. LIHP provided network services. We asked LIHP to tell us about the kind of network support services that they had. Referral guidelines and review and authorization of referrals were frequently employed as methods of support, and obviously they were very important in the ability of the LIHP to provide specialty services. We did also ask about, in the previous slide actually, we also asked the LIHPs to tell us whether they employed TPAs or third-party administrators or pharmacy benefit management organizations to help with some of the functions of that are required under the program and the network. And here are the kind of activities that these organizations conducted on behalf of the LIHPs. Most common were claim processing and member services on the part of the TPAs, and then prescription claims processing and adjudication, and pharmacy network management on behalf of on the part of the pharmacy benefit managers. There were some other types of services, obviously, that were performed based on what the low-income program perceived as needed. We asked a number of questions on the health information technology, or HIT, in LIHP, and we also asked them whether they had health information technology, and about 5 of the LIHPs reported that they did have electronic medical records, and others that reported they had other types of electronic information. We have details of what these services or the functionality of these programs. Here, as you can see in this slide, there are certain types of information that were most frequently available patient demographics and lab results were frequently available. And there were some other services that were a little less frequently available, but particularly important if you're trying to help providers deliver, follow the processes of care, appropriate processes of care, such as reminders and for medications or preventive services. We did ask the contracted clinics who responded to our survey whether what features of the HIT programs were available to them. And this is the types of features that were reported that were frequently available, and these included patient demographics and medication lists. But some of the services that also were available but on a less frequent basis included drug formularies and prompts for medications or preventive services. We particularly asked them about asked the LIHPs about collection of performance measures, and as you can see, utilization patterns and patient satisfaction were most frequently reported, and also we'll talk about this particular point a little bit later some more. Moving on to the challenges that were reported by the low-income health programs about the HIT or LIHP network support particularly, and as you can see here, cost and IT staff availability and capacity were particularly challenging, and also additional challenges for telemedicine were also reported, and specialty referrals were also reported by some as challenges, and we talked about some of these before, particularly shortage of personnel to review referrals and provider adherence to referral guidelines. Now we're going to shift to talk about changing patterns of care seeking and care delivery. As far as the changing patterns of care seeking were concerned, we were particularly interested in knowing whether there were any barriers to some of the counties in terms of adherence of the patients to their assigned medical homes. And we had asked this kind of information. We know that a number of counties, legacy counties, had required adherence to the medical home because they had noticed a lot of movement around enrollees moving from provider to provider and high rates of ER utilization or hospitalization. So what we find from the clinics, they told us that among those clinics that were responding from LIHPs that enforced adherence, some of them were still having issues in individuals not adhering to their medical home. And we also had some of the new LIHPs particularly that did not enforce adherence, clinics reporting that adherence was an issue. We asked also LIHPs whether they actually provided training to providers on conducting teamwork and also being able to conduct care coordination. And you can see those results. The conducting care coordination, training PCPs on care coordination was more frequently done, but also many of the LIHPs conducted training on teamwork for the PCPs or the primary care providers. We asked the counties also to tell us about partnering with community-based organizations because medical homes also, or part of the network requirements and the medical home requirements is that you're able to identify social service providers that could provide additional services. Here there are a number of different mechanisms directed at disease and self-management services. You can see that disease and care management services were provided by many LIHPs. Some of the diseases were more commonly managed than others, particularly diabetes, for example. The educational materials that supported these kind of disease management services are also reported here at the lower left-hand side. We also asked about training health educators by the low-income health program, and also evaluating the level of risk of the enrollees so that those individuals can be managed more appropriately. And you can see all of that information here. We did ask whether the low-income health programs were providing some of these services directly, and here are the results. The smoking cessation was most commonly provided. In terms of quality improvement initiatives, you can see providing evidence-based clinical guidelines was frequent. Reporting performance measures to providers, this is particularly important in changing practice patterns. That was also frequently provided, and organizing continuous quality improvement committees that could address specific issues around care delivery were also commonly provided by the low-income health program participants. Looking at contracted clinics and how they reported about the impact of the low-income health program on their day-to-day practices, you can see that many of the clinics reported that they found improvements in specialty care, access, referral, easy to use referral system, ability to manage referrals, and reduced wait time. Contracted clinics also reported that they are including staff in their team meetings, and however, this is not necessarily a direct result of the low-income health program. We didn't ask that, whether it was because of the low-income health program or not, but it gives you an understanding of providers and how they are changing their care delivery patterns. So including medical assistants, particularly nurse practitioners, registered nurses, the type of individuals that can enhance the ability of the primary care provider in delivering care. There are improvements in that area. We asked the contracted clinics to tell us about what services they particularly use and how helpful they found those services. These are services provided by the low-income health program. And there were use of services was reported by 14, particularly in terms of disease management programs, and 6 of the clinics reported services helpful. May I ask everyone else that's on the call to mute themselves? Thank you. And so we also asked about use of educational materials and health promotion programs. One thing to note here is that many of the clinics that were participating in the survey had extensive level of information available to them. They had internal disease management programs they were already using. They had educational materials, etc. So lack of take-up of these services reported by these clinics does not necessarily mean that these services are not, doesn't reflect necessarily on the utility of the services. It probably reflects more on the kind of internal resources. Moving on to the next section, we also spent some time on integrated physical and behavioral health care. And this is probably the most challenging part of this survey. This is also challenging because these benefits are relatively new to the, they're mandated benefits under the low-income health program, and frequently siloed type of services between physical and behavioral health. This is just a model from the HRSA model of care integration that kind of shows a continuum of integration. And I'm not going to spend time talking about this one due to shortage of time, but provide some insights on what's expected. As you can see, counties' low-income health programs had made some progress in this area, developing referral systems for behavioral health, providing some health information technology resources, and incentives to use those resources. We did ask behavioral health providers if they could access physical health records in some of the LIHPs, and you can see what they reported in terms of what they had access to in this slide. In the next slide, we asked whether there was co-location of behavioral health and physical health providers, and on the left-hand side is behavioral health providers co-located in primary care facilities, and most frequent type of provider was counselor or therapist. On the other hand, having physical health providers co-located in behavioral health, most frequently there were nurse practitioners in those types of facilities. Talking about challenges to integration, here you can see, not surprisingly, funding and limitations in workforce are the two major issues that were identified by the low-income health program participants, and then there are other types of challenges that are listed here. So in conclusion, from our analysis of and all of the discussions we had with low-income health programs and the clinics, we think that there was significant progress made in system redesign in the low-income health program in general, beyond what was particularly defined and required in the contracts and in the program. There were many innovations and innovative practices that you can find in detail in the report. Particularly, two important implications of what the findings are in this report are that individuals that have gone through the low-income health program and are going to transition to Medi-Cal will most likely have a lower level of need in many areas. They should experience perhaps better outcomes and hopefully reduce costs. And safety net providers and counties that participated in the low-income health program also benefited from many of these things, because particularly the infrastructure and changing provider behaviors. And that concludes my presentation.
Thank you very much, Nadi, for your presentation. We just wanted to acknowledge one more time the Blue Shield of California Foundation and the California Department of Healthcare Services for their support of the evaluation and of this project. And I just wanted to one more reminder for anyone who is on the phone line to mute the phone when not speaking. And if there's no mute phone button on the phone, you can always hit *67 to mute the microphone. I'd like to turn now to Dr. Jennifer Tuteur to describe some of San Diego County's experiences with the low-income health program. Dr. Tuteur?
Hi, thank you. I'm going to talk for about 5 or 10 minutes about some of the things that we've done in San Diego that our providers have really liked about LIHP, and I know there'll be time for questions at the end as well if any of these topics you have further questions. Some of the things that we focused on are exactly what Nadi spoke of: mental health integration, expanding the provider network, improving access to care, looking at different ways to do referral systems, and also developing health IT. Our goal overall in San Diego was to help improve the care and the systems at the community health centers, which are our primary care providers, knowing that the LIHP population was a very small percentage of their overall patient population, but using it as a way to help them prepare for healthcare reform and Medi-Cal in 2014. So basically using the LIHP population as a pilot for change. And one of the ways that we did that is we looked at ways that we could adjust the payment schedule based on some of the outcomes that we were hoping to see with LIHP. We did this in conjunction with all the providers so that the providers gave us input as to what was important to them and how we could support what their needs were. And we also looked at what providers needed to report on already and picked those items that we also thought were very important to this specific population so that we weren't adding on more work for providers. And I think that's something the providers really appreciated. Some of the things that they wanted to do were to improve HEDIS scores and clinical outcomes, look at mental health integration, and really try to find some better access and specialty care for their patients when they needed that. So starting with mental health integration, we are one of the legacy counties, so we've had 2.5 years to look at different ways that interventions have worked and not worked and tweak those as we move forward. So we have both a quality improvement committee that meets quarterly. We have monthly reports that go out to the medical directors and the mental health directors to give them updates on their quality performance. And then the community clinics have developed their own quality improvement committees and multidisciplinary teams around these core functions. So with mental health integration, we focused on two things. One was our high rate of readmission after a mental health hospitalization, and a lot of that was related to connections in care and transitions in care in the community between inpatient and outpatient, and between specialty mental health and primary care. And then the other thing we focused on were the use of atypical antipsychotics and what those risks in the physical health world were for the patients in decreasing life expectancy and so forth. So what the providers ended up really liking is that we could eventually come up with monthly reports for both the mental health providers and the primary care providers of these patients to let them know who was hospitalized and what the plan of care for follow-up was afterwards, and also who was taking or prescribed, actually filled an atypical antipsychotic, and assisting the mental health and the primary care providers in coordinating and treating for abnormal glucose and abnormal cholesterol, as well as trying to get folks into primary medical homes. If they normally had just been having access to behavioral health, how can we communicate to them and work as a team to help address some of their physical health needs? So we started with annual reports, and the providers liked the data, thought it was very helpful to them, and ended up with monthly reports that once the mental health providers saw that the primary care providers were getting, the mental health providers wanted as well. And so the mental health providers, sometimes for the first time, were able to see who the primary care provider and the primary care clinics were for these patients. We too have expanded provider networks just with the volume of patients and looking at different ways to contract and reimburse. We've also working with an electronic consultation system. So for 10 specialties, we have basically email or secure website conversations between a primary care doctor and a specialist. So we're trying to get the right people at the specialist and have them already be prepared and worked up to a point that the specialist can assist them. And the other thing that we've done is, as far as health and IT development, is part of our P4P or payment adjustment rates have included not only the HEDIS or the quality measures and the mental health integration, but also patient-centered medical home status. So in working in conjunction with our Council of Community Clinics and some of the grants that they have secured, both for EHR and for patient-centered medical home accreditation, we've been able to support that. And also we have been able to support their successes in network adequacy, and we do that through secret shopper calls. One of the things that providers have really appreciated through that feedback is, as we do secret shopper calls, we are able to give them feedback as to what their own staff are saying and scheduling appointments and so forth. And what some of them have done is learned to create scripts that are common throughout all their sites, or learned to have different scheduling systems. People have changed different phone systems, not realizing that there were issues. And folks now, after 2.5 years, several of the clinics are conducting their own secret shopper calls where their managers call and get an idea firsthand of what their staff's saying and informing patients so they can use those as teaching experiences. So I think I want to stop there, and I know we'll have questions at the end, but just trying to stay on track. Those are some of the highlights of what the providers here in San Diego have appreciated about our LIHP implementation.
Thank you very much, Dr. Tuteur, for your comments on San Diego County's work. I'm going to turn now to Dr. Alexander Lee of the Los Angeles County Department of Health Services.
Yeah, thank you, Max. Good afternoon, everyone, and happy belated holidays. I just came back from actually New York City. Just want to share with you that, I can't tell you how many countless family and friends, and as well as just speaking at my alma mater medical school, how everyone's asking how California is doing. So I think this conversation is probably fairly epitomizes the spotlight that California faces with regards to the low-income health plan, as well as the Affordable Care Act. So basically, as you know, we agree we're basically at the doorsteps of January 1st, 2014, and basically, in our mind, at least in the Department of Health Services, we basically are, I guess I'm now hearing the legacy term for the LIHP program, but I guess we're viewing this as that we're fortunate to have the 2 years to be transformative in some way to get to the starting line. And I think part of it is it needs for us to not just enroll the individuals with coverage expansion, but also kind of reframe and remodel or rejigger our delivery system. So I just want to point out things that I think we probably all know, and I think was highlighted by Natty as well, was that, you know, I think for the efforts that we've all done across California, we've not only helped patients gain insurance coverage, but in some sense, we also gave them the freedom of choice in some way to choose to stay within a safety net system or to use other contracted Medicaid providers once January 1st, 2014 hits. And I think in some way there's also advantages for us too, in the sense that the safety net, we also gain new revenue from insurance payments having more Medicaid patients. And I think furthermore, it also gives a chance to think about how to be more organized, as Jennifer mentioned, to provide equitable care and access for patients that traditionally were the payer mix would have been a capitation of 0 for those with uninsured to those now with a capitation, but also how to think about delivering care more effectively and marshaling new resources and partnership. So just as a background, our Department of Health Services were basically constructed of 19 freestanding clinics. We have contracts with over 60 community partners who we're really fortunate to collaborate across Los Angeles, as given our geography of 4,200 square miles. We also have 2 academic affiliations that provide the bulk of our specialty services and teaching programs, and 4 hospitals. So I think with regards to how this comes impact us is that we are actually not just worried about patients having choice leaving our system with now that they have access to primary care and a network, but also the impact it has with regards to potentially a paradoxical effect of having more capacity with our specialists because it was designed for a system with largely uninsured individuals. And so with that sense, I think it's kind of creating and stitching that network with the safety net and the partnership with the safety net clinics to ensure that there is a good balance of primary care patients as well as specialty care patients. And I think the hospitals are, I think I heard from that was mentioned before, that it's really a free fall in some way. Having 4 hospitals doesn't really provide you with a great chance with regards to bringing the patient back into your network per se, given the size of our county. But in some way actually allows us to rethink how we do care transition, which was another term I heard, with regards to bringing back our own assigned or impaneled patients back into our network. I think the other opportunity that this provided with us is also marshaling our staff who work, tirelessly and for years in the safety net system with the mission of providing as much care as we can to the community who are vulnerable, but really also thinking about defining our customers. Who are our customers that we want in our system? Are there ones that are more long-term, partnerships and relationships that they should be, where they should get their usual source of care at the patient-centered medical home, or are there those who are just more episodic where they use an emergency room? And I think the other challenge that we see too is that in a safety net system, and maybe more so because I'm speaking as a public agent, that sometimes in the safety net system we may not be able to change or readjust our fixed costs as fast to adjust to the changing times. So one of the things that Natty asked and Max asked me to kind of speak very quickly on, or at least give an overview, is the importance of developing patient-centered medical home. I think we see this as not just a local trend within LA County, but also across California as well as nationally, meaning that I think we're thinking about how to have a longitudinal relationship with patients. So we have to think about our capacity, and some capacity may be brought on or onboarded with new providers. But I think many of us are also thinking about how do we maximize workforces that are more readily available. For example, certified medical assistants or LVNs or nurse practitioners, to bring them on board as to be a team as opposed to just a purely hierarchical or pyramidal approach towards care. Also thinking about improving our infrastructure around phone systems, making sure our staff answer the calls, help people schedule, investments in computers as we move on to electronic health record systems, and also just simple things are making our infrastructure more patient-friendly or inviting for patients. Where we see other areas where we are not as successful as maybe as a public system, and I'm not just after listening to Jennifer, it sounds like they're much more advanced with regards to think about billing, coding, HEDIS, and things like that, or contracting. But I think even just on simple things of, again, not trying to ensure that people have a kind of a vision or kind of a relationship building with a standard team or usual team and provider will be key, I think, as we move forward. So those are some of the, I think, the sociological, infrastructural capacity challenges I think that we're thinking about with regards to our PCMH, where we kind of have to deal with a behavior, I think, that was enabled both by our system as a safety net as well as our patients with regards to really not making that connection between the patient and the PCP on a regular basis, and also having being socialized too with, I think, in a way of not being accustomed to serving those with people who previously, that people with choice now, well, who will have choice in the near future, but accustomed to serving people with historically with no choice. So with regards to like building and customer service type infrastructure or kind of, I think behavior will be key. I think some other advantages we see with regards to PCMH is that we really believe that as a safety net, we've built a tremendous amount of foundation with regards to having linguistic and culturally appropriate staff. We feel that the safety net has traditionally bartered and kind of developed relationships that needs to be formalized, whether it's with university or other safety net providers or specialists. These all have to be kind of more formalized or contracted. And also even within safety nets, thinking about both the public as well as the not-for-profit FQAC or community health centers. How do we work together as a system? Because there are still going to be those who are going to be residually uninsured, as well as connecting to other services. And I think one of the things that was alluded to, and it's something that by Jen that we think about too, is how do we integrate mental health, food programs, general relief programs into the system. So I think with regards to mental health, I just want to highlight that we have, over the 2 years, whether it's legacy or transformative, worked closely with our sister Department of Mental Health to develop co-location sites. It's not the only model, but there's many models to develop that's in the field and in the literature, but this is the model that we put our dime on. And I think part of this is, as many people know, it's not just having staff co-located, but it's really about process and communication and figuring out who is the primary care or provider for that patient at that particular time and who's the secondary or the specialist. And knowing when to kind of do those handoff and exchanges will be key. And we're also trying to figure out how to have more formalized process for patients to transition for when they need higher level of mental health needs. So making sure that type of linkages or handoffs are there so that we can actually make it work. And other things that lessons learned are also just basic understanding of like communication around like electronic, paper, and so forth, follow-ups. So these are just some simple things that operationally it sounds easy to do. Intellectually, it sounds easy to just do a co-located site, but operationally, it takes time to develop over time. So I think with regards to how we think about it, we think that the way we've been messaging is that ACA is incredibly important. Success is really the only good option for both us as a public safety net system as well as for the not-for-profits. We have to figure out how to increase our access, improve our customer service, and we're going to have, as much as we can, an equitable level of care for both the uninsured as well as the insured. So I wish everyone the best of luck with everything as we go through this next phase of our journey here.
Thank you very much, Dr. Lee, for your insights into some of the work being done in LA County. I want to move to our final speaker for today. It's Rachel Wick, who is from the Blue Shield of California Foundation. Rachel?
Hi, good afternoon, everyone. I'm Rachel Wick, Program Officer for Healthcare and Coverage here at the Blue Shield of California Foundation. First, I just want to thank the UCLA team for this terrific report, the webinar, and all the hard work they've done to support counties and the state in making the low-income health programs a success. And I also appreciate their invitation to join you all on the call today. I also just want to celebrate and acknowledge the hard work of everyone involved in the success of the LIP programs. And in the foundation world, there's a lot of talk about something they call collective impact. And I can't think of a better example than the LIP program, the development, implementation, evaluation of the LIP program. And pretty early on, the foundation recognized the potential, I think, that the LIP programs could have in expanding both coverage and access for low-income residents. My colleague, Richard Thomason, led a lot of the foundation's work in this area, and we've tried to do everything we could to support the range of activities related to the LIPs, and that includes work to plan for the LIPs, development of the LIPs, implementation, evaluation, and now the massive undertaking underway to transition LIP enrollees into Medi-Cal and covered California. And we've also provided grants to an array of stakeholders that were involved in the work, and that includes counties, states, UCLA, and other consultants that have been instrumental in making the program a success. In terms of this report, while we love all the evaluation work UCLA has done, this one is particularly exciting. I think it shows the tremendous progress that's been made in transforming the delivery system. We knew LIPs would expand coverage and access, but I think the delivery system transformation work is especially exciting. And for the foundation, it offers us a blueprint, I think, around the challenges and opportunities that we can address in the future. And so that's what I just want to highlight today, kind of where, as we read this report, the observations and lessons learned, where we see the foundation going and some of our priorities in 2014 that I think really link to the progress that's been made, but also some of the challenges that remain. And so the first one I just want to mention is the remaining uninsured, and Dr. Lee touched upon this. The foundation is really interested in working with counties that want to continue to use their LIP infrastructure to serve the remaining uninsured. And how can we support these efforts? So I just want to encourage everyone to get the word out that that's a priority for us. And if there are counties out there that want support and help in figuring out how to use LIP infrastructure to serve the remaining uninsured in their county, we want to work with you. The second area that we're looking at is how do we continue to support some of the safety net integration work that happened through the LIP and has also been supported through some of our other grant-making efforts. And I'll just sort of talk about three component parts of that work. And the first one is some of the innovations that we're seeing to improve access to specialty care, which we know remains a challenge. We have a couple of grants actually that we're bringing to our board this afternoon to support telemedicine implementation and policy change focused on telemedicine in the safety net. And so that we see as a potential innovation and solution to addressing some of the gaps in specialty care access. And then it's also great to have both Los Angeles and San Diego on the line today because both of those communities have also worked on e-consult, e-referral systems to improve access to specialty care. And I know Dr. Tuteur mentioned the work in San Diego, and there's also been some exciting work going on in LA. And we want to continue to support other communities, other both LIHP and non-LIHP communities in implementing those kinds of strategies. We know that they are having an impact in terms of the triple aim. The second area is behavioral health integration. There's been a lot of discussion about that in the report and in the webinar today. We think there's some work to be done at the system level, the county level, that the county's working in partnership with safety net providers to really push an integration strategy at the community level. And then at the level of the individual provider, we're particularly interested in kind of the fully integrated model that I think was on the far right-hand side of Nadi's slide, and that's having team-based care approaches that really support integration of behavioral health and primary care. And team-based care is another kind of area of focus for the foundation in 2014, and how can we support that, and how can we use that approach to further behavioral health integration. And then the last kind of prong is the care coordination and transition between hospitals and community health centers. I know that's been touched upon today in the call. Frequent utilizer populations, as well as readmissions challenges. Those are areas that the foundation wants to continue to support work around in 2014, because we know there are big challenges there in terms of kind of using appropriate services and also controlling costs in the system. And the last area that we continue to drive work around is payment reform in the safety net. And I know a lot of the care delivery transformation work sometimes gets stymied by the way that we pay for health care in the safety net. And so we continue to work with the association, CPC, the California Primary Care Association, California Association of Public Hospitals, to drive new methods of paying for health care that can support some of the innovations that we know are essential to delivery system transformation. So those are kind of the big areas of work that the foundation is interested in pursuing in 2014, and I know that my email hopefully is on the slide, and just encourage to get in touch with me if you have ideas, thoughts, work that's going on in your community that aligns with the goals and areas of activity that I just outlined. So, thank you.
Thank you very much, Rachel, and I just wanted to one more time thank all of our speakers today for their valuable comments. And I wanted to move briefly into a quick Q&A session in the few minutes we have left. And again, if you have any questions, and if we cannot get to them during the webinar, we'll do our best to respond to them offline. But there is a Q&A pod in the lower right-hand corner of your screen. I wanted to make sure we got to one question that touched on the patient perspective. We've talked a fair amount and heard a fair amount about system and county level and provider level experiences. But one question was if we have any information on the challenges that patients experience in adhering to medical homes. So we saw in Nadi's slides that a fair number of clinics cite adherence or non-adherence to medical homes as a problem. Do we have any information on what patients perceive as problems in that? Perhaps Dr. Lee or Dr. Tuteur could address that question.
Well, we've done a couple things in San Diego. Every year we do have a patient satisfaction survey as well as a provider satisfaction survey, and those have been very positive, in part because of the core services that are provided, and in part because of case management and transportation, as well as the support to the patient-centered medical home or to the primary care clinic. And we have assignments by the actual site of the community health center. So some community health centers have more than 10 sites, but we assign and help patients select their patient-centered medical home according to that site. And then part of our quarterly quality improvement report is looking both at the number of visits that are conducted at the medical home site and the number of enrollees who have used their medical home site for every single visit. And so we're in our 9th quarter, now starting to enter our 10th quarter of collecting this quarterly data. And we are now up to 84% of all of the primary care visits are conducted at the medical home site. So that's almost 27,000 visits, and 85% are conducted there. And the other 12 are conducted at a site within that same parent organization. So only 3% of visits in San Diego are outside of the community health center parent organization. And then if you look at the number of enrollees who are using their medical home site for every single one of their visits, we're at 90% of enrollees use their medical home site for all of their visits. So those are the different ways we've looked at that patient perspective.
Great, thank you. Dr. Lee, do you want to add anything on?
I think it's too early to tell, because I think for many of us, we're probably still working through our empanelment assignment or PCMH model. But I think also that I don't believe that the LIHP population has really understood that they actually have choice yet. But I think it will take some time for that to be sink in before we see some major shifts, I think.
Okay, great.
I was going to add a little bit to that. We actually, from the data that we are collecting, we are interested in looking at the relationship between adherence to the medical home and outcomes such as rates of emergency room use or hospitalizations and visits to specialists and all that. And in fact, there will be some information related to that in a new report that is describing the overall experience of the Healthcare Coverage Initiative, which was the first Medicaid waiver with all of the legacy counties. So I just wanted to have people to keep everyone posted and looking for that report sometime in the near future.
Great, thank you very much. We only have about 1 minute left, but I just want to get one more question in, which is to what extent is substance abuse treatment included in behavioral health care, and how do primary care providers identify those who need substance abuse services? Nadi, do you want to speak to that in terms of LIHP coverage?
Well, we actually don't have sufficient amount of information on the substance abuse beyond the fact that we know some of the LIHPs have decided that they were going to cover substance abuse services specifically. We have not looked at utilization or any of that information. Perhaps Jennifer can describe.
Sure. San Diego is one of the counties that do not include substance abuse as part of mental health. So it's been quite a challenge. For example, we have one of our HEDIS measures. We focused on 9 HEDIS measures, and one of those is counseling for tobacco cessation. Yet we don't cover, because of what our benefits exclude the substance abuse, we don't cover any Nicorette gum, for example. And so we've really had to work through that over the past 2.5 years and listen to what the providers need and to what our mental health system is able to provide. So we are doing a couple of things. We're measuring, asking, and working with the patients to cover not only mental health and physical health needs, but substance abuse needs, not only through our HEDIS measures with tobacco use, and one of our QI projects is opioid dependence, and we actually run lists of what the morphine equivalent is for each of our patients filling prescriptions for narcotics. So we run some of that data, and we feed that back every month to the providers. And then, because we don't cover the services, we've worked with mental health to come up with list and universal referral forms and all kinds of referral sources for those substance abuse programs that are then not covered by LIHP, but they're covered by the County of San Diego. So we've tried to do some integration there, both substance abuse, mental health, and physical health, in some sense coordinating care by coming up with that universal referral form and different listings of what resources are available in different parts of the county. And then thirdly, our case management staff does screen not only for mental health issues, but for substance abuse, homelessness, and so forth. So that is part of what we consider taking care of the whole patient. It's just the service isn't covered, and therefore we coordinate it. So for mental health, we have mental health integration and try to co-locate, and what we're doing with mental health, we're not doing with substance abuse, but probably what we're doing with substance abuse is along that continuum of at least trying to encourage communication and referral sources.
Great, thank you very much. I'm afraid that's all the time we have for the webinar today. So I just wanted to, again, thank the Blue Shield of California Foundation and the California Department of Healthcare Services for their support. We'd also like, as the authors of the report, to acknowledge the LIHP and the LIHP providers for their contributions to LIHP itself and also to this report. And if you'd like any further information, and also it looked like there were quite a few questions coming in. If you have a question that you would like answered that we didn't get to, you can feel free to contact Nadi Porat or me at the 2 emails that are listed on the screen right now. And more information on the LIHP evaluation and other projects that the center is doing are available on the 2 websites at the bottom.